All right, thanks. So thank you everyone for joining. I see there are a bunch of participants who are already joined. So I think we should probably get started. But first, I'll make some introductions and starting with Dr. Arkader. Alexandre Arkader is a pediatric orthopedic surgeon and orthopedic oncologist at Children's Hospital of Philadelphia. He is one of the MSTS members who will be presenting his cases today on reconstruction of benign and malignant bone tumors in kids. Dr. Nicole Montgomery is also a pediatric orthopedic surgeon and orthopedic oncologist at Texas Children's Hospital. She will be presenting her cases as well, and she'll be discussing, in particular, I think some of the more challenging areas in the things that can happen, especially in kids, and how we can manage that. And Dr. Daniel Prince is an orthopedic oncologist at the Memorial Sloan Kettering Cancer Center here in New York. And he will be discussing some of his cases as well and some of the challenges that can occur in the long term. So I think without further ado, we'll get started. Dr. Arkader, you want to?
Can you introduce yourself, Karim?
Oh, well, yes, that's true. I'm Karim Masrouha. I'm a pediatric orthopedic surgeon, orthopedic oncologist here at NYU. I'll be presenting some of my cases as well. Hopefully, these cases will engage some discussion amongst the panelists today, and we welcome questions from the people who are attending as well.
Thanks, Karim. Can you guys see the screen?
Yes.
All right. All right. Yeah, good evening, everyone. So I'm gonna start easy. I'm gonna give some of the easy cases, some benign stuff, and then it gets complicated as the hour goes on. This is mostly to stimulate conversation and discussion. And also, I'm gonna ask questions to the panel, and then I think everyone that is listening can ask questions to the panel as well in the chat, right? Is that correct? All right.
Yeah.
So the first case is a fairly typical case, a 9-year-old that came in with complaints of pain around the hip and this progressive limp. And he came in with X-rays. Also came in with the MRI, which is, already helpful. And that's kind of the picture that we had. And I'll start asking any of you guys that want to answer. This is a typical case of a 9-year-old coming in with pain and then this extensive lesion that has some pretty classical features. What do you guys usually do when you see something like this? How do you counsel the patient? How aggressive are you guys to actually do a biopsy to prove whether something is or it's not fibrous dysplasia, or you're comfortable with this kind of workup and then you can move on with the treatment? Karim, you're unmuted. You can be the first one.
Yeah. So I think, as you had mentioned, this does look fairly classic for fibrous dysplasia, in addition to the deformity that's starting to develop. And, I think even though there's a certain level of confidence with the imaging and, we can potentially just call it what it is. I do prefer to get the biopsy to confirm. It is quite an extensive lesion, and the planned procedure, which I'm sure you're going to show, will likely contaminate the whole area. So we want to make sure that we're not dealing with a potential sarcoma, which is again unlikely but possible always. In addition, one other potential option is getting a frozen section intra-op. You plan your procedure, you get a frozen section. Problem with frozen sections for fibrous dysplasia can be a little bit challenging, can sometimes look like a low-grade osteosarcoma. I vote for getting a biopsy, proving what it is, and then.
Good. All right. So I love that we already don't agree on the very first question of the night, which is awesome. It shows that there's no right and wrong, right? So Nicole and Dan, if you get a biopsy, raise your hand. Oh, yes, we win this one.
Yeah.
You want to say something, then you're unmuted.
No, keep going.
All right. Okay. So I think that it's all about history and physical exam and the imaging, right? And Kareem is absolutely right. I think if you're not comfortable with something, you can't be, too cautious to not get a biopsy. But I think if you see enough of these, you feel pretty comfortable. Now, this kid, and it says there, has progressive limp and pain. Normally, if most of the fibrous dysplasias present in a monostatic way and an asymptomatic way, and then you're following, and then if those things develop, is a whole different discussion in terms of the deformity, etc. But if the kid is having pain already, and there's any concerns about potential stress fracture, progressive fracture, I usually go ahead and treat. And if I'm going to treat, I do agree with getting the biopsy at that time, not relying necessarily on the frozen. So this is what I did. I did a ream nail for this kid, and we confirmed the diagnosis of fibrous dysplasia, and he did really well until 4 years later. Now he comes back, he's limping again, and he has pain in the insertion site for this nail. Nicole, what would you do now? What do you think it's the cause of his pain at this point?
Yeah, so at this point, he's grown off the nail quite substantially. I think, and he's developing a mild progressive varus deformity of his proximal femur. At this point, I would exchange this nail. So I would remove this one and put in a new one.
Awesome. Anyone would do anything different?
Yeah, I would do a corrective osteotomy at the proximal femur. I would just get in there with a Lizarov technique, and I do perc osteotomy, and I would drop it, use the same nail. I would just get a better alignment overall. I think it's less likely to cause progressive deformity over the course of time and have the next nail cut out. Although at this point, kid's probably like close to 13, so it's probably not that much more growth left, right?
Yeah, I agree. I mean, that's the thing. Those nails in the younger kids, and I use for pathologic fracture, etc. You have to tell the patients, the families, that you probably have in some time you're gonna have to remove it or change it, so on and so forth. Now, I did exactly what Dan told me to do. So I did do a corrective osteotomy. And then I put a nail, which can be challenged because you're trying to move the starting point and you have a big hole in the bone. Also, those kids tend to bleed quite a bit, and the bone is not great. So I wanted just to highlight, and if you guys want to weigh in, but in my experience, all those fibrous dysplasia proximal femurs can be pretty tricky. I avoid trying to grab the bone with any clamps. That's why you see the little plate that it's used. I tend to use the osteotomy, put a little plate to hold the reduction during the reaming. Often the plate falls apart when I'm reaming because there's not a lot of room there. The second thing is that those kids do not have a well-defined canal. So this is one that you want to tap your ball tip guide and really get a lot of pictures to make sure you're going to create a canal in the middle of the bone. And this is very different than something like this. So those deformities, the true shepherd's crook deformity, I think they're like a much more complex deformity because they're in three planes, right? They're in the coronal plane, they're in the sagittal plane, but there's a lot of version as well. So you have to be really careful when you do correction on those. So we've done, 3D printed models to try to understand that. We've done a lot of recons, so on and so forth. But the deformity tends to be the same, right? Varus, procurvatum, and retroversion. So those are a little bit more complex. Any other comments on fibrous dysplasia proximal femur? And I'll pass it along so you guys can show other cases.
Yeah, I think the corrective osteotomy is a good idea, and you obviously shift to a trochanteric entry at that point. Doesn't have to be lateral anymore, and then the screws going across the physis just so that you don't have to deal with this again. In the few patients that I've dealt with that I've treated with proximal femur fibrous dysplasia, especially as they present fairly young, sometimes I do tell them that's probably not the last time you'll get surgery. I think that's like giving them a heads up that this is a challenging one. It's kind of almost like osteogenesis imperfecta bone. hardware kind of just sticks
it is
out at some point.
bad bone.
Yeah.
Definitely bad bone.
Yeah.
All right, thank you guys. I'll pass it along. Alphabetic order is Dan is next.
All right, Dan, you're up.
Oh, I didn't realize I'm alphabetical. My bad. All right. So just so everybody understands, we have not rehearsed any of these cases or practiced any of this in advance. I can share my screen. Hopefully this
It
is
makes
going
it
to
more
work.
exciting.
But we're still very professional people.
I hope.
We're
Always.
not going to beat each other down.
I'm hoping this is gonna work if I go to full screen here. Did that present properly for you guys? Or do you see the presenter screen?
We see
We're
a
seeing
presenter
the
screen.
presenter.
Oh, switch that. Sorry.
We see a Spurs sign there too, which is weird.
I know, isn't that odd? Is that working better now?
Yes.
Yes.
That
All
looks
right,
great.
good. Yeah, so I don't know if anybody's aware, but this is going to be over by 8 o'clock because there's a game going on tonight afterwards. So anyway, this is the one thing that makes orthopedic surgeons stay on time is sports events. So I'll give an example. I don't have a lot of benign cases, so we are kind of jumping around. This is going to be a malignant case, obviously, given the title. And I tried to pick some really young kids because I think these are the ones that really have a lot more controversies, and I think you can go in many different directions. I think many those of you who know me know I'm really a one-trick pony. My answer to most everything is distraction osteogenesis. It's what I do. It's what I'm good at. Although I do love vascularized fibulas, I think those are the only two biologic answers. So this is a 3-year-old female and a few months. She's high-grade osteoblastic osteosarcoma, non-metastatic, undergoing routine chemotherapy and normal timing of surgery. So neoadjuvant chemotherapy, surgical timing, and then rest of chemotherapy. We know we know now that the kid had a chemo responsiveness of 80, but obviously we don't know any of this in advance. So we'll come up a little. Here we go. So this is her presentation imaging. You see bilateral image pasting. You see a lesion in the distal femur on the left side. It looks pretty concerning for an osteosarcoma. That's the vast majority of what they look like. And then obviously an MRI shows a pretty well circumscribed lesion in the medial distal metaphysis with definitely some changes on the other side of the epiphysis, or the physis here into the epiphysis. And I would argue that the medial aspect of the uncalcified portion of the cartilage or the epiphysis here, as well as the physis here, are both abnormal when you compare them to the other side. And so that certainly worries me. You could see on the on the axial view, as you might expect, that after chemotherapy, there's not a lot of soft tissue component. Sorry, this isn't osteosarcoma. That's the next one. There isn't a lot of soft tissue component to begin with in this particular patient, thank goodness. So a relatively straightforward resection in terms of muscle resection and ligamentous resection. We will have to take, based on the surgical plan, we will have to take, something. But I think this is an opportunity where I'll stop and I'll ask each of you in order. We'll go backwards. So Karim and then Nicole and Alex, what would you guys do in each of these circumstances for this case?
Yeah. So this is this is obviously a challenging age group. There's the loss of growth potential and limited reconstructive options. One of the best things that we can do for this patient to minimize a number of overall procedures and provide the best function is to do a rotation plasty.
An excellent option. Nicole?
Yeah, I think I would favor rotation plasty here as well.
Fair. Alex?
Yeah, I'm a big fan of an S. I think that the kid's distal femur, with, debatable whether you can save the joint well or not, but you can't save the growth plate. I think, my preference is rotation plasty. However, I think it's very important to give the family options, right? So I give all the options, and then when they ask what would you do, then I say rotation plasty. But it's also depends what they're willing to tolerate. I think that if they're willing to go through a few surgeries with predicted complications and obstacles, then you have other options. The one thing that I wouldn't favor here, it's putting metal, right? Endoprosthesis. A growing prosthesis in a kid this young, for me, that would be in the crazy category. I wouldn't do that. But biologic reconstruction, I'm all in, even though I would vote on Vanessa.
Yeah.
Yeah, I think if the component the tumor was not involving the physis that aggressively, and there wasn't that area in the epiphysis that was concerning, you may opt for some sort of joint preserving procedure. But I think here it just will be extremely challenging, very risky. But
So I'm glad
possible.
I agree with you guys all. I think it's almost as if you guys have seen my talk, which I know we haven't. So you're right. I think these are the four options. I don't put them in any particular order there. Let's just go through them quickly. And I think these are the case for a lot of these cases we're going to talk about around the knee, especially. The benefit of an above the knee amputation, as you all say, is one surgery. It's an excellent oncologic surgery, right? And so I have an asterisk on one surgery because it's not a small percent of kids who get standard above the knee amputations or below the knee who end up with overgrowth of and I think people have tried a lot of creative things, periosteal sleeves or in the femur, Ertl procedures in the tibia, and I still think I have seen a fair amount of overgrowth. And I have a partner, Dr. Forsberg, who does a lot of amps, and I see it in his patients as well, despite everything that they try to do. So I say an asterisk because I think the literature would say there's like a 10 to 15% chance of another surgery, but that's a pretty minor surgery. So that's fair. I think the question about future consideration for osseointegration, I think, is now something that we should all be thinking about, in everybody, not just adults. And my question, I don't have an answer to, but I'd be curious if one of you guys or if someone in the audience has experience with doing osseointegration in adults, because I don't think of many people doing them in kids at all, in an adult after they've had an amputation from the age of 3. What is the quality of the bone in that area? Is that going to hold an osseointegrative device? Those are the kind of concerns and questions that I have. The negatives for an and above the knee or below the knee, it's ablative and definitive. So as there's no changing your mind. If that doesn't work, you're done with you've made that decision. You are dealing with prostheses for the rest of your life, and we all know there are socioeconomic decisions about that. And then I would say, RPNI or any of these other new techniques should strongly be considered, in the sense that, but I don't know how you could do that now in anticipation of future osseointegration. So I should have put the future osseointegration almost in yellow color, because I don't know where that is, if that's a favorable or not a favorable thing, that it would limit the person's options for osseointegration in the future. I do think osseointegration and RPNI are going to be the standard for patients getting amputations, if they're not already the standard. I apologize if I'm mansplaining this. RPNI is a technique where the nerves at the level of an amputation, and there's a lot of variations on this, are plugged in to muscles in a very predictable location, and sometimes they're looped back into a muscular nerve, where the major nerves that you cut are plugged back in to another local muscle or wrapped in muscle, with the purpose that that nerve can later be used to detect signal, and so it would then be able to control prosthesis. Rotationplasty. Yeah, everyone voted for rotationplasty. I see why. It's a great choice. One surgery, excellent in every category, right? Well, excellent oncological surgery. You're going to get widely negative margins. Excellent long-term function. That's been proven. Again, it is an ablative procedure. I think some folks argue whether it's ablative or not. I think it is. You're dealing with prosthesis for life. And I would argue, I do these, but I don't do as many of these as I do distraction. Rotationplasties are hard cases. And in the cases that we're talking about, like, these have a high risk of complications as well. Not just infection complications, but other issues as well. So I don't think that
one of the challenges I ran into was the soft tissue. I underestimated the complexity of the soft tissue reconstruction and where things can go wrong.
The one question I was going to ask is, for how many people who would say that a rotation plasty is really a one surgery, one and done.
Probably not at this age.
Yeah, not at this age. They can actually de-rotate over time at this age, so they may need a correctional rotation osteotomy in the future. You know, and then you have the risk of the wound healing complications as well, which is pretty standard with rotation plasty.
Well, as much as you do your distraction osteogenesis, I think I do rotation plasties. I don't think the main causes for revision, if you don't do math correctly or if the residual growth isn't ideal, that's a problem. Then you might need to do some adjustments, epiphysiodesis, so on and so forth. I've had a few patients not heal, either did too much or just the biology, etc., had to revise a non-union. My experience in spontaneous derotation, like Nicole mentioned, it's true, but it's mostly for the congenitals. I haven't seen oncology patient do that yet. It could happen. I just haven't seen it. So, and I think, overall, it's a very long surgery. I don't know if it's that difficult, like people say, especially for distal femur, where all the attachments that control the foot and the ankle are in the tibia. You don't really need to do any soft tissue reconstruction in that regard. You know what I mean? So, I mean, obviously I'm joking, it's a difficult surgery, but it's not. It's very doable.
Mm-hmm.
Okay, I agree. Good to hear that. So obviously there are the other next option would be some kind of joint salvage. Again, I won't put it in the same category and say it's excellent oncological surgery because by definition we're coming closer to the tumor and the soft tissue, and so there's always more of a concern. It does have, I think, excellent long-term function as well. The negatives, as many know, is multiple procedures, including future lengthening surgeries to address, the loss of the joints or the loss of the epiphysis, the physis, and future length. And then again, I think somewhat technically complex procedures. I would say the same thing as Alex. I don't think that these are. I think that these are based off of trauma surgeries and trauma principles. I think the hardest part about distraction is dealing with all the complications that come up. And I think that's actually the complicated part. Yeah. I think that's the hardest. And then again, expandable prosthesis, I agree. I had put this here just to be thorough and honest with folks. I also would not do this in a 3-year-old. It has to be a custom implant. If you're going to get any kind of actually expanding mechanism in there, you end up removing more bone than you need to fit the expanding mechanism in, which always never made any sense to me. I think it's good short-term function, but I think the long-term function is really poor. And I think there's plenty of studies that show growing prostheses. I mean, there's some better versions perhaps now, but even just mega prostheses in kids at this age typically don't do well.
I would almost guarantee, even in the appropriate age group, that, or at least that's what I would tell parents and patients, is that once we're done with the expansion, I would revise to a definitive endoprosthesis, just because of those complications.
Yeah. So we're back to the case, and of course I tried to pick a controversial case. So I did not do a rotation plasty. This was the surgical resection that I planned out, and I did. You can see I was
hoping that's what you would do.
Yeah, I wanted to pick something different. So I did. I lost the physis. That's okay. The epiphysis, is another location of growth, right? So the uncalcified cartilage of a kid is a growth plate, right? In the sense that even if you enucleate the epiphysis, that uncalcified cartilage will grow. But so here's the resection. It's a big defect. I ended up using a combination of distraction osteogenesis and vascularized fibula so that I could not shorten so much and still try to maintain some length. So this is a vascularized fibula. The medial one is the one that's vascularized. The other two are just some extra segments that we had. Here's some, you could see, I try to quote unquote navigate these. These are guide wires that I use to navigate, done under fluoro. Now this is a bit older of a case. So now I do these with actual 3D navigation. And you could see some contrast in the joint. So you can actually see here, it looks like these are in air. They're actually in the non-calcified portion of the distal femur. This plate looks kind of crazy. Unfortunately, this is a technical error on my part. I put the plate in a little bit of varus, or I put the distal femur in a bit of varus. That was kind of silly. And now I'm kind of struggling with some distal varus, but I did a corrective. This is all in the same reconstruction. So a plate internally and a frame to regain the length that you lost and to correct the alignment. You see she's intentionally in some valgus. It heals kind of cattywampus. Those of us in the pediatrics world, we say we don't care what the middle of the bone looks like. We care what the joints and the alignment looks like. After being in a frame for this much time, I swapped into a plate, and she does okay. So here's now, fast forwarding. Her alignment is a little bit in varus, but nothing terrible. And then I go for my first lengthening at this point, so I can have a chance to do a little bit of a corrective osteotomy. I didn't want to get too close to the distal femur to correct that remaining varus, so I did an osteotomy there just to correct the femur so I could get a straight nail in. Again, the nail's coming in through the greater troch up there, and then we do a lengthening through the proximal aspect up here to equalize leg lengths at that time. I do put screws in the distal fibula every time I take out a fibula, because I have seen a lot of kids drift into valgus. There isn't the case that I joke with my colleagues here at work that the only time I don't have a case to present at M&M is when I don't operate the week before. So here's a failure of the plate right at the crux of where the stress riser is, right at where the varus was and where the nail is pushing on, unfortunately. So, that stinks. Revision, longer plate, more cables, and a longer nail. So I didn't lose length, thankfully. And I got a little bit of a better correction on the angle distally. And now here's this is the most recent x-ray. She's going to be due for a lengthening probably in the next year. And at that opportunity, given that the distal femur is so well healed at this point, I would advance the nail into the femoral shaft here, and I would advance the nail here and do an osteotomy distally to correct the final bit of varus that's residual. But I can't not point out to you guys all that if you look at this x-ray from way back when, distal to these wires and distal to this screw, there was nothing in the epiphysis, right? Kids are amazing. And then you leave it alone, and look, that's the same screw. And you leave it alone even longer, and a medial condyle forms in the bottom here. And this kid has 130 degree of knee flexion and full extension, and she runs around like a regular kid, and you wouldn't be able to see it.
Love it.
It's an amazing question for you. I mean, it's a awesome case. You do have to stomach some of those complications. So that's obviously part of it. Now, one of the participants asked a question is, what makes you think that your epiphysis was involved? And now, piggyback to that question and ask, if you didn't think that the epiphysis was involved, would you consider do a Canadell type, physial distraction prior to your resection, so you didn't have to do like this V-shape resection and then get some length?
Yeah. So the reason I thought the epiphysis was involved, I'm going to answer the first question. I didn't pull up all the MRI sequences, but I don't know if you can see, I hope my arrow is showing up. I can try to highlight it or something, but here we go. I guess this works.
Yeah. No, but the cursor is showing up.
Okay. Yeah. So here, these are changes on the other side of the epiphysis that look very similar to this. The other changes in the MRI were also relatively consistent. It could be that some of this change in the epiphysis and the physis medially are chronic reactive changes. I don't know that I would want to come closer and find out, about this in that way, to find out that that's okay. So you're losing the epiphysis in this patient no matter what you end up doing, in the sense that, you are going to do a cut here. I don't know anybody would do a cut on this side, on the proximal aspect of the epiphysis. That would be way too close for any of us, I think. So, you're losing the physis. So to me, taking a little bit more bone, that allows me to have a little bit of a wider margin in that area that I think is closest makes sense. And again, the medial collateral ligament reconstruction is relatively straightforward. It heals really well, especially in a 3-year-old kid. Yeah. Alex, to your question, the Canadell technique, I've only done it twice. As much as I love XFix and distraction, you need a perfect sort of circumstance for it, in the sense that, my worry is always that, as you're pulling apart the physis, you could pull apart the tumor bone, because it has to be, and this is an osteoblastic osteosarcoma, which is the one that he originally described it for, because it hardens up, right? As opposed to, like, some of the other ones where there's no bone and it's a lytic lesion. I worry if you put a frame on that and you pull across, you're going to fracture through the tumor, as he describes in his, his original paper. So I've only done it twice, and it's really been when the lesion's further away from the physis. And the 2 times I did it, I thought I was just doing it because I kind of could, not because I thought the patient needed it in that sense.
And are you ever doing a distraction?
That physis doesn't grow. Sorry, one last. That physis, if you save it, it doesn't just continue to grow on it all. All you're doing is getting a wider margin. Sorry, Karim.
Yeah. Oh, my question was, if it's further away from the physis, in any of your patients, have you done like a distraction across the physis prior to resection, or
no?
like
I've
cutting through the
twice.
physis
I've done it. I've
Okay.
done it twice, but in situations like this. Yeah.
Okay. And then, so Dr. Gebhardt makes an important point that I think is worth mentioning. The surgeon doesn't have to stomach complications; the patient does, obviously. And
I think we both do.
point.
I think hopefully I would say we both do, right? I don't know.
Yeah, we live with
I
it
don't feel
too,
good.
of course.
I don't feel good when a patient comes in with a complication, right?
Yeah.
I know I'm not feeling as bad as the patient does,
Yeah.
but I mean, in our world, I think all of us are experiencing the fact that every day, it's not like it was in the past. Every day, every patient expects 0% complication. That's a new thing, right? Nobody ever wants to be the 1% of complications. So I don't think that that's any easier now than it was before. I think it's harder now, in the sense that, having to explain why that patient is the complication is really hard.
Yeah. Awesome. All right. So I think we can move on to the next cases. Dr. Montgomery, do you want to go?
Sure. All right. Can you see my screen?
Yes. It is in presenter mode.
Okay. Let me swap. All right, can you see it now?
Yeah.
Okay.
It just needs to be enlarged, I guess. To presentation mode, I guess. That's the one.
Yeah, hold on.
There's one question, just while we're working on that, is does the chemotherapy timeline change, knowing that you might have a lot of surgeries? Do they get more chemo up front? Is that how it works, or does anything change from the chemo timeline, or is it pretty standard?
I try to stick to the standard timeline at all times. I try to get patients back on postoperative day number 21, like all of us. Our data has shown that these more complicated surgeries, I don't know if they're any more complicated at the initial resection, are different, that they don't have an increased risk of, delaying chemotherapy. And my plan is to never intervene during the next 6 months of chemotherapy at all. I do all subsequent surgeries after chemotherapy has been completed. The only time, I think, is probably the same as any of us. If you get an infection during chemo, then you got to treat that infection whenever, whatever is on the inside.
Yeah. All right.
All right. We good now?
Yeah.
All right. So my case is a giant cell tumor of the proximal ulna. So this patient first presented at 12 years old. She's an avid softball player with left elbow pain, had this lesion through her proximal ulna with non-displaced pathologic fracture. She had workup with MRI and biopsy, which was consistent with giant cell tumor of bone. Underwent curettage with adjuvants, bone grafting, and ORAF. Initially, she did well. She was able to go back to softball, but then on surveillance visits and imaging, started to have pain and new expansile lytic lesions. I got the ever humbling MRI, which showed a likely recurrence of her giant cell tumor. This was again biopsied and confirmed to be recurrent giant cell tumor. So I would like to ask our panelists at this point, what do you want to do?
Well, I'll start so I can give the easy answer. So I think that in this case, you could consider some medical treatment to add to the adjuvant of your surgical treatment that you're gonna have to do afterwards, and I'll let the other two decide what surgery they want to do at this point. The one question that I had, what kind of adjuvants do you usually use for giant cell tumor in particular?
I use argon beam and hydrogen peroxide and sterile water washes.
Okay.
Does anyone do anything differently?
I use cryosurgery. Dan probably is going to do the same, but just because our training, I think, and I don't think it makes a significant difference. If anyone in this call feels strongly about one adjuvant being superior to the other, please put in the chat. But I've always done cryosurgery.
I do what you do, Nicole. I do consider the high-speed burr an adjuvant, for what it's worth.
Yeah, so I thought this patient needed a wide local excision for definitive treatment of her tumor, but I didn't have an immediate answer as to how to reconstruct that. She did not want another major surgery at that point, wanted to continue to play softball. So we did temporize her with denosumab infusions. She had a nice response with consolidation of her lesion, but I was planning, after a year or so on denosumab, to take her off of it and do a definitive surgery. Her goal was to get back to softball. We talked about, how it may not look the same, regardless of how we reconstructed. But I felt that an allograft probably wouldn't be a durable reconstruction option in her, and she's at significant risk of fracture with her activities. If that fractures, it's not going to heal. Likewise, you don't want to do any sort of custom metal implant in a 12-year-old in the ulna. It's not going to last. So I went to the epiphyseal free fibula flap as my reconstruction, and I love free fibulas as a biologic reconstruction option in kids. So we resected the ulna. We did an epiphyseal free flap because we didn't need an active growing physis. So we were really just using it for the joint surface. We were able to take it off the perineal vessels, which allowed for a longer pedicle. There's less risk of injury to the perineal nerve with perineal versus AT-based fibula flaps, and then attempted to do an anatomic ligamentous and triceps repair. These were her initial post-op images. Her elbow was stable throughout range of motion in the operating room. And then this is her about a year or so out. And she has a stable elbow. She still lacks full extension, but it's actually better than her pre-op motion. And she has full pronation and supination. And she was able to return to softball and actually had the highest batting average on her team. I hadn't used, so I've used epiphyseal free fibulas most commonly for the proximal humerus. I hadn't used it in this anatomic site before. I've used it for the distal radius and for even the distal fibula, but interested to see if any of our panelists would have done something else.
I think it's a brilliant option. I don't think I would have thought of it, but I'm not really sure what I would have done. These are challenging because obviously we see giant cell tumor in skeletally mature individuals. I've had to deal with a recurrent giant cell tumor in the proximal ulna that I'm now temporizing with denosumab, and I'm still figuring out what to do. The patient does not want to have an arthroplasty type procedure because of the lifelong limitations to weight bearing with the weight bearing restrictions. And so it is hard, and trying to get a nice biologic reconstruction in a young patient. The proximal fibula is really our workhorse, and it looks like it's been it did a good job here. How did you do the soft tissue reconstruction?
So I actually brought in one of my upper extremity colleagues, and he helped do an anatomic ligamentous reconstruction. We were able to save a fair amount of length on the ligaments, and he used suture anchors to repair them to the fibula. Obviously, you want to be pretty judicious about putting any sort of implant in the fibula and disrupting the blood supply. But we were prepared to even, pin the elbow. We were not expecting it to be as stable as it was on the table. Maybe we just got lucky.
And the distal triceps tendon?
Again, with suture anchors, and then we also repaired that to the biceps, which was still attached to the fibula.
That's great.
Yeah, hard to argue with a good result, right? I mean, I don't think we would. That's why you got Dan Prince to be quiet there. That's how good the result was. It's a very creative way to treat this. I haven't had that opportunity to do it. I hope I don't have the opportunity to do it actually. But I've used fibula physio transfer to the humerus and other places. And my experience, it works best in the younger kids. So I'm really impressed that this remodeled that much in this age. So did you do any special rehab program? How did you get this to remodel so nicely?
No, I mean, we kept her splinted for the first 6 weeks, and then we put her in a hinge brace and slowly, worked on her motion. She was under the supervision of an occupational therapist, for the first year or so, until she was going back to softball. And I think that's a large part of the success. And we still have her wear a brace when she does softball, just for stability.
Comment from the group from Dr. Mark Gebhardt. Great case. Proximal ulna allograft is also an option. But long-term, maybe not as good as with this patient. So,
yeah, I considered it. I mean, you can get a great matched allograft and a nice reconstruction. The thing that made me nervous with her was the risk of fracture. And I guess maybe if you do fracture the allograft, then you can always, default to the fibula or something more creative as your next step.
Yeah.
The risk of perineal nerve dysfunction, when taking the epiphyseal-free fibula is not insignificant, especially if you're taking it to use it for physeal growth, like in the proximal humerus. So you really have to counsel patients on that risk.
My rate is 100%.
What?
My rate is 100%, although they recover eventually.
But they usually recover. I work with a very experienced microsurgeon, Chris Peterson. He feels if he's taking it with the anterior tib, that it is better, and he manages all of this. It is better to sharply transect the nerve and do an acute repair than to stretch it and potentially have it not come back. So that's his practice. If we're doing an AT-based flap, he will, if he feels like he's going to stretch the nerve trying to get the fibula out with the pedicle, then he'll just go ahead and transect it, primarily repair it. And so far, all of them have come back.
Nice. All right. So
that is kind of amazing, I have to say. I mean, I realize acute repair of a nerve has a higher likelihood for success, but that is a gutsy maneuver as well. Is there more literature on that? I would love to know more about that.
He presents it at micro meetings across the world. He needs to, I don't know if he's published it yet, but he needs to. I mean, it makes me pretty nauseous, but he counsels the patients up front. He manages the foot drop. And like I said, so far they've all come back.
Our
Amazing.
micro does the same for anterior tib base flap. The motor branch is cut and repaired, and we have a similar experience of return of function.
Yeah, seeing how it's done, it makes sense, to be honest. That nerve gets a lot of stretch. All right, so should we move on to the next one?
Yeah, close this out.
Mhm.
Your turn, Karim.
I guess so. All right. All right. See my screen? All right. This what you see everything?
Yes.
All right, great. All right, so I have some proximal and some distal tibia, proximal femur and distal tibia tumors. So disclosure. All right, so we'll dive right in, I guess. Another 3-year-old Dan, so but on the other side of the femur. Presented with a limp, no pain, and this terrible looking X-ray. Suspicious for primary bone sarcoma. This was his MRI. You can see the intramedullary extent is pretty distal, large soft tissue component anteriorly. Biopsy confirmed osteosarcoma. There were 2 small lung nodules, 4 millimeters. So he was started in the AOST arm C, basically, for potential metastatic disease. I put him in a little hip brace like this to prevent fracture. What are you guys initially counseling the patients for with regards to local control? Alex?
Tough location, tough age group. I think rotation plasty is an option here. It's going to be more like a Brown modification type. Another option is to use a free fibula. I think if you're going down that route, you definitely have to, again, counsel the family and the patient on the risk of complications and need for revision surgery and possible failure. I would not use metal in a patient this young, so that would not be an option. Even in older patients, if you try to replace the proximal femur with metal, you'll get acetabular dysplasia, which can lead to a host of problems. So I think, rotation plasty and free fibula reconstruction, probably maybe with an allograft just because of the length. And then for completeness sake, hip disarticulation.
Yeah, it's a little bit different than the other one that then showed, right? I mean, for one side, the amount of growth, it's not as much, right? It's 30% of the femur instead of 70% of the femur, so that's kind of helpful. On the other hand, it's a harder joint to kind of reconstruct, stabilize. Amputation is a much worse surgery here, right? Because the hip disarticulation is not super functional. Um, I think that the options that Nicole listed, of course, are the standard good options. I think the rotation plasty is a good option. You would probably have to use your knee as a hip, right? So then now you create a second problem. You're gonna have a hinge for a knee, but it can work well. In the past, I've used the vascularized fibula, the epiphysis, to substitute the whole thing, right? So epiphysio head into the hip. Obviously it's hard. We've seen one picture. I don't know how much we can save of the proximal femur, or if anything. But one thing is that this is also sarcoma, right? So you don't expect the picture to change dramatically even after chemo. So right from the get-go kind of what you're gonna have to deal with. And it's important to start kind of seeding the plant with the patient so we can get to a place where they're comfortable and it's the best for them.
Yeah, so I had multiple conversations with the parents from the beginning, kind of going back and forth between rotation plasty and free fibular reconstruction with an allograft. I tried to go through the MRI and potentially see if I could do something similar to what Dan did, but in the proximal femur. Like, can I save that femoral head, that capital epiphysis somehow, and dock some sort of fibula in there, and I just couldn't find a way that I could do that comfortably. So not very far from surgery, so let me just show you. So this was an interim X-ray that I got just to make sure that he hadn't fractured and he was still doing okay in that brace. And then his soft tissue component responded dramatically, which was really good and made the surgery a lot easier. But I just didn't expect it. As you mentioned, osteosarcoma, we don't usually see this dramatic soft tissue reduction, and it's usually something we expect in Ewing sarcoma. So very soon, his surgery was coming up basically, and the parents basically, because I was basically teeing him up for a rotationplasty at that point, and then the parents were like, "Hey, let's try this free fibula thing." So I got together the plastic surgery team, and we planned it and did our measurements, and so the rotationplasty, as you mentioned, would be a Winkelmann B3A, so the lateral plateau would be in the hip joint. And then hip disarticulation, pretty bad idea. And so this is what I did. I created a green stick fracture in the proximal fibula to kind of give it that varus shape, and pinned it, and used a distal tibia allograft from an adult that was matched somewhat to the femur. And I was able to, preserve the physis, as you mentioned. That's an important point here. I was able to get away with doing this in Nicole, you mentioned the length is a challenge here, right? Because there's a large resection, and there's only so much fibula that you have, and so I was able to get this within 2 centimeters of the other side. So it was about 1.5 centimeters, I think, limb length difference, which I hope if the fibula survives, then that gives me some length additionally, and so maybe the overall limb length difference may not be terrible. If it is, there eventually this distal femur, obviously has another 13 years of growth in this boy, and so later on I can always come back and lengthen through that as needed, or also, if this falls apart completely, which it likely will at some point, replace it with a proximal femur endoprosthesis if it survives until his teen years. At least that's my fallback. And then obviously the parents were aware that the ultimate fallback is a rotationplasty, but now he's missing a fibula on the other side. Comments, I guess, on the reconstruction.
One comment about the rotationplasty. There are other options. You could keep the distal femur. And I'm not going to try to be an expert on rotationplasty, but you don't need to put the tibia into the acetabulum. You could do a pelvic osteotomy, open up the pelvis, and put the distal femur into the pelvis so that you kind of lateralize it a little bit, and you just get a little bit of a better hinge. In my limited experience with those types of reconstructions, but that's more for congenital stuff than tumor stuff. So I don't know. I don't have enough experience to say that that's better or not.
One of the challenges I think with that is that you lose abduction if so it becomes like a flexion extension only.
Yeah, you'll just get flexion extension, but that's the paleo modification of the Brown procedure.
Okay.
Yeah. I think, that's what Alex was saying, I think, in terms of limited range motion. But in a young kid like this, I've seen a lot of remodeling where over time you don't regain abduction fully, but you seem to have some laxity to the joint, and it's remodels that it does give you some improvement.
I agree.
I'm curious about this. I'm curious from the audience if anybody has any thoughts about these proximal femur reconstructions. Classically the answer was this doesn't work. Vascularized fibula into the proximal femur doesn't work. My other case that we're not going to get to, which is fine, is an example of it not working from many years ago. Have things changed? I'm curious, do we think plastic surgery techniques are better? Are these vascularized fibulas better? Like things like we've talked about, cutting the nerve to save the fibula. Like, I don't think we used to do that kind of stuff, but I'm not an expert in the history of this. So it seems like things are different, just generally speaking, going to MSTS meetings and other things, people are presenting a lot of information on vascularized fibulas with great results that previously we didn't used to see in the literature.
Yeah, Dr. Gebhardt made a point of sharing, the known data on the proximal femur reconstructive hip physio that from Dr. Manfrini, that 5 out of 6 had failed. That's kind of somewhat of my experience. If you think about 20 years, 30 years, I think they're all going to end up failing.
Hmm.
The discussion is if you do this in a 3-year-old or in a 4-year-old, and you're able to man it to until they're a teenager or a little bit older, and then eventually you convert into an endoprosthesis. Okay, so that first treatment failed, but it bought you 5, 10 years. Is
Yeah.
that a true failure? If you're able to, I don't know. I mean, it's a philosophical question.
Well, that was
Again,
my issue with them calling it a failure, because I don't think they were failures, and they called them failures, it's just it bought them time to do the surgery that you would do if the patient had presented when they were 15, you know, I think, at
yeah.
least. Dan, you already mentioned about the syndesmotic screw. It seems like there's some consensus on that.
Let me ask a question. Let me push back. So if we're using these as a spacer,
Mhm.
why not use something that's more anatomic, like
Mhm.
a proximal femur allograft? Assume you can find something small enough, a humeral head. Why try to make this anatomic if we're just trying to get 5 to 10 years out of this till they're bigger and we can do a real hip in them?
Yeah, I mean, I agree with you. I mean, it's both sides of the conversation. And I don't know which side I go to. I don't, I struggle with those cases. I think we all do. That's why we are presenting. That's why we mix some easier cases with very difficult cases,
Mm.
because I don't think anyone has the real answer.
Yeah, that's true. I'm going to quickly go through. I know we only have a couple of minutes. Go through this. This is a patient, also a 3-year-old, also came with a limp, but very different situation, right? So maybe there's some expansion here of the femoral neck, but definitely something abnormal going on. So I get an MRI, and you'll have to trust me here that there are fluid levels. Uh, and so uh, and so this was read as an aneurysmal bone cyst in the 3-year-old. Um, what would you do? Go back to the how do you approach it? Are you going to do a lateral cortical window? Or are you going to approach it anteriorly? Direct visualization. Aneurysmal bone cysts are notorious, even in young patients. What do you think?
Yeah, I mean, I think you could go two ways. You could go surgically, which I would do a lateral window, place a proximal femur locking plate with smooth-ended screws, and cross the physis. I feel like you have to because of the location of the lesion. And then I usually, will curettage the lesion, decompress it, put in a doxy foam, and then an injectable bone graft substitute. I think the other way you could go is through interventional radiology. So we, for ABCs, we'll have the IR docs inject doxycycline foam. Sometimes they will add alcohol sclerosing agents and cryotherapy, and then inject a bone graft substitute like Prodens. With this location, you'd have to be comfortable then managing them either in a fracture brace or a cast, and making sure that it healed adequately before you let them loose. But I think now we have options.
Yeah, I think that's great, and I've definitely decided on shifting towards vascular intervention radiology for a lot of these cases. And one of the challenges I think is that they end up needing to do more than one procedure, and so I was trying to not have multiple procedures over a short period of time. And I was also worried about the risk of fracture, as you mentioned. And this patient was treated before we had access to that nice fancy brace. So I did what you mentioned to begin with. So I went in lateral cortical window, drilled, curetted, grafted, and smooth pins. And I like these pins. They grow out, which as you can see here. And she healed pretty well. Hardware came out, and there's like a 2-year follow-up showing that she's doing really well. So
I think that the message here, Karim, is yeah, we do sclero for some ABC cases, but the message here is that when the potential complication of the treatment is worse than the disease, then you should avoid it. And the worst thing here, and that's true for ABCs and mostly for UBCs, is a proximal femur fracture. So
exactly.
whatever you can do to avoid that, that's what you should do,
Mhm.
and be a little more aggressive.
And
I know
I
we
think
may be over.
even worse than that is the patient who doesn't follow up, and then they grow off their plate and they get a periprosthetic
100%.
fracture. We've had a run of those. So I agree with, I usually take the plates out around 2 years as long as the cyst is not recurring.
Exactly. And that's also another question I ask myself, about hardware removal in the setting of a benign aggressive bone tumor. When is it okay, and at what point? And I think that can be a little bit challenging. Real quick, just because we had a fibrous dysplasia in the proximal femur, this is another fibrous dysplasia in the proximal femur. Unfortunately, this patient had a pathologic fracture. It was treated with this at outside institution. The bone lesion itself wasn't appreciated, I guess, during the initial treatment. And then subsequently she healed, but you can see that the lesion over there, and then hardware was removed. And it wasn't until after the hardware was removed that it was noted that there is a lesion and that now she developed a pathologic fracture through it again, non-displaced this time. So I guess I know what Alex and Dan would do. But the patient had a lateral scar, and I just wanted to go through the same approach, and so I decided to plate. I initially plated, and then I curetted, and then I put in some strut allograft from a fibula. I don't know if it's the right thing to do, the best thing to do, but that's what was done, and she's 6 months post-op here. It looks like the graft has taken pretty decently, and she hasn't developed any deformities. So hopefully this will hold, because turning this into an intramedullary nail would be very challenging after putting in the strut allograft there. I think that's probably all we have time for. Stop sharing. And there looks like there are some questions real quick before, if everyone has an appetite for staying.
We covered most of the
did we cover most of the questions?
The question about Vanessa and Nicole's experience with the brown modification of Vanessa.
Yeah, absolutely.
I've only had to do the brown modification for congenital femoral deficiency, so I can't speak to it for the use in a tumor. Patient, they end up with a hinge hip joint, so they have flexion extension, relatively good function.
Yeah. Great. And then let's see, do we have any sclerotherapy? Definitely, as mentioned as well. Awesome. All right. Well, thanks everyone for staying on for the duration and a little few minutes over. Thank you to Nicole, Alex, and Dan for these awesome cases and great discussion. I almost wish we can do this every week. Actually, I do wish we can do this every week. That would be great. It's a lot of fun, and hopefully it was of benefit for the participants, and hopefully we'll plan something similar soon.
Thanks for organizing. Appreciate it.